Welcome everybody. Today is the first module of the colorectal webinar series, a series of 11 modules centered around different colorectal subjects. 11 different subjects ranging from basic laparoscopic colorectal skills and continuing with more complex procedures as the series progresses, to D3 lymphadenectomy and at the end TEMIS and transanal TME. The colorectal webinar series is meant for general surgeons and beginning colorectal surgeons who are willing to move forward with minimally invasive techniques and who are interested to progress and increase their knowledge for colorectal techniques. So I'm happy to introduce our faculty of today. We have three standard faculty members who will be there during the whole series. And every week or every module, we have a guest faculty member. So the first member I want to introduce is a good friend of mine, Walter Brunner. He is an Austrian surgeon working in the Department of Surgery of St. Gallen, the Kantonsspital, and he is the head of gastrointestinal surgery there. Welcome, Walter. Second member, also part of the main faculty, is Andreas Chamillier. He's the head of gastrointestinal surgery of Kepler University Clinic in Austria. Welcome, Andreas. And our guest faculty member today is Victor Tomulescu. He is the head of gastrointestinal surgery of Ponderas Academic Hospital in Bucharest, Romania. So welcome all. My name is Colin Sietses. I will be the moderator of today, and I'm working in a hospital in the Netherlands, the Gelderse Vallei Hospital, which is somewhere in the center of the Netherlands. So this is the program of today. Andreas will start off with the basic laparoscopic skills meant for colorectal surgery. Walter is going to progress to anatomy and the approach. And then Victor is going to tell you something about training in Romania and also about what he thinks training for general colorectal surgery should look like. And at the end, we have some time for question and answers.
Thank you, Colin. Welcome everybody to this meeting, and as Colin said, it is 11 modules, and so we will really start with the very basics, which I think fits to the audience because only a few have experienced more than 50 colorectal resections. Myself, just one slide. I'm 49 years old. I'm the chairman of the Clinic for General Visceral Surgery at the Kepler University in Linz. And I have experience of more than 1,600 self-performed laparoscopic colorectal resections and procedures, and also have experience in witness at CURT since more than 12 years. So I will bring this in the very beginning. So after this module, you won't be able to do a complete colorectal resection. We will start with the basics. And the aim and the goal will be that the team, Colin, Walter, Victor and I, we will just give you an idea of one safe or two safe ways, step by step, module by module, to perform good laparoscopic colorectal surgery in benign and malign disease. So the goal of my 20-minute presentation will be a safe, to show how to do a safe procedure, oncological correct procedure, bloodless procedure. This must be the goal of each colorectal surgeon, to perform a safe anastomosis, to try to give the patient ideal conditions for a fast recovery with a low morbidity, low mortality. And of course, if you do major procedures like colorectal surgery, you should be able to manage your complications. And this goal will be always within the following modules over the next weeks. So to start with, We don't start with the operation. You have a patient and you have to bring this patient in the best optimal condition, meaning that you see the patient before the operation in an ambulance setting, and you check out the blood supply, you check out if there is a protein, a lack of protein, a lack of hemoglobin, and we have lots of data on that. Just 3 examples summarized in ERAS: enhanced recovery after surgery, meaning that you start before surgery to take care of the patient and to bring the patient in the best possible condition on the table in the OR. The next step is to be safe from the medical-legal aspects. You give a good patient information. In the best cases, you do it as the surgeon yourself. In our clinic, we have a really tough rule. The rule is each surgeon knows his patient and each patient knows his surgeon. So you're not allowed to do an operation when you never have seen the patient before. And then you have to fill in with him a written informed consent. Lots of standard information sheets are available. Use this like Diamate, Pro-Compliance, these sheets, and explain on this sheet separately the indication, the reason for the operation, and then explain the technique. And you always have to explain, if you want to do it laparoscopically, that there's an alternative way, the open way. And if you do it open, the alternative way is the laparoscopic way. So you have to give your patient, and this is not only for colorectal, the information that you have different ways for the operation, and you have to explain him why you prefer in his personal situation the laparoscopic way. And if you do it laparoscopic, always be in mind that there's the possibility of conversion. Write this down on the sheet of paper, on the information sheet. Make drawings, make extra remarks, and you have to explain, although everything is written in, you have to explain and write down typical complication, which means like leakage, like reoperation, like postoperative bleeding, like the necessity of a stoma, maybe during or later, few days after the operation. These are typical complications and happenings which you have to explain the patient in colorectal surgery, and you have to write it down. And in the best case, the patient has at least, for elective cases, more than 24 hours time to think about it. And then you take it, you talk again to the patient prior to the operation, and you do a good documentation in your computer system, what you talked and when you talk to the patient. After this, of course, it's really necessary, and Walter Brunner will talk on anatomy and planes, to make an intensive study of the patient's history, that you don't have any surprising during the operation. Look yourself the CT findings, the pictures, not only the written report. Go to the MRI, go to the collateral illness of the patient, if he takes any anticoagulation medicine. The flexible endoscopy, how to mark the tumor. Try, if you are able, to look the bowel inside, the rectum inside yourself, or go to the gastroenterologist, and then prior to operation, ask them or do it yourself to mark the lesion. Mark it either by clip or by spot, so that you can do the correct operation. And the red sentence is just the most important information. You as a surgeon, you have to know prior to the operation what you definitely are going to do. You have to have a plan. You have to have a strategy, and you can do this for yourself if you don't know all this data. Some pictures here, as you can see on the left slide, a CT scan. There's the tumor is just at the rectal sigmoid, and the picture itself, so that you know prior to operation what you're doing. If you're in a good lucky situation, like in our clinic, We have a cinematic rendering CT scan, which provides us pictures like that, so we can study even important in the right colon or in the Riolan situation, in low rectal cancer, the vessels, the complete vascular anatomy of the tumors, which maybe helps you to do a better strategy for the operation. Marking the tumor, here you can see a video how it looks like. We always do a marking with a spot with a blue and also a clip. So this is on the transverse colon, and there are the Oxford criteria, which you can go and look yourself. Due to time reasons, I don't show it here, how and where you do the marking, the Oxford criteria of spot marking of tumors, which is in laparoscopy very important because you're not able to bring your hand in and palpate the tumor. And my personal experience, don't trust any gastroenterologist which you don't know, because they write in the report tumor in 20 centimeter and then you find a rectal cancer in 8 centimeters. So always check, recheck, double check. And here you can see this is just a case where we had a tumor from an outside gastroenterologist reported in 50 centimeters. And then during the operation, of course, we checked it and we marked it. It was a rectal cancer in the mid part of the rectum. Here you can see the marking. So it would be a really surprise, and the planning would be completely different if you don't check the height of the tumor yourself. So the next thing from the basics is, it is impossible that you get new modern instruments from the companies which you haven't trained outside the OR. So you have sealing systems like the ligature system. We have cutters, conventional cutter, linear cutter, electric driven. It's important that you know how to use these staplers, how to do a reloading. But maybe you get a new nurse and she can't do the correct reloading. It's the most important part of the procedure, safe anastomosis, how to use the staplers. Also the circular stapler, they are now powered, 3 staple lines, 2 staple lines, analog, mechanical, different staplers. You have to be familiar with all these instruments, and this must be trained outside the OR so that you're really familiar with your instruments. Just 2 examples. On the left slide, you can see a mechanical analog standard linear cutter called endogear or endogear. And here there's the Signia, which is completely powered, force controlled, different to change the magazine. And you have different magazines in color, which means different heights of the staples inside, which is important to use the right magazine, the right cartridge for the right tissue. So a very thick rectum needs a different magazine as a small bowel. On the stomach, you need also a different one. And there are also different sizes of the magazines. Here you can see 2 videos. On the left side, you can see the mechanical, where you have pull in your hand to push the staples. And on the right, you can see the powered, forced, electronical driven, completely different instruments, and you have to know how to use them. Otherwise, you might fail in the most important part of the operation. Sealing systems. On the left side, an ultrasound system. On the right side, you can see the ligature bipolar feedback control system. They all have a collateral heating, and you have to know what is the collateral heating and how close can you go to the bowel, and how does the sealing line work, how does the knife inside work. You have to train this, and I think Victor will talk to you about training on these instruments and how to do the learning curve with these instruments outside the OR. Inside the OR, for colorectal laparoscopic procedures, it's very important to do the right positioning of the patient and then to do the right placement of the ports. So I won't show you the only one, the one and only. There are different ways. The blue one is the optic port for sigmoid or rectal cancer, might be good for you. Other one, as we do it in our clinic, is the optical port here and 3 ports for the instruments here. I think the most important thing is that you get a standard for you and your clinic and try to do it almost the same way, the same procedure, so that the nurse, the residents, and everyone knows left column ports like that, right column ports like that. You can do it single port +1, single port +2. However, you have to find, and we will show different ways in the next models, you have to find your standard for a standard procedure, how to place the monitors, how to place the first assistance. You can see here in our clinic monitors. You can see it's necessary that you work with your anesthesiologist together, that you bring the patient in for a left colon in a steep anti-Trendelenburg position. You can see the head now. The head now goes nearly 20 centimeters above the floor. Otherwise, if your anesthesiologist does not work with you, you can do this positioning. You won't be able to do successful colorectal surgery. And here you can see a picture of our. The better is you use more monitors than one, then every surgeon can see without looking just left side or right side. That's very comfortable. You have to stay comfortable because in the beginning, these procedures might take some while, more than 2 hours. So if you don't stay comfortable, you will get problems with your spinal cord. Of course, if you have the chance, you can do it in 3D or 4K. But the most important thing, I think, is that you have at least full HD and different monitors for each position. Next step is you have just basics. You have to be able to show the region of interest, which is in that case the sigmoid. And therefore you have to bring out the small bowel. If you can't do this, this is an acute emergency operation of a sigmoid perforation. If you can't bring out the small bowel like that, you won't be able to do a good procedure. And for that, for grasping the bowel and the small bowel, I always recommend to do not use the arresting function of the clamps. So just open the arresting function that you can just touch the small bowel very gently, but train in the positioning, steep anti-Trendelenburg positioning, removal of the small bowel, that you have a good view of the region. And if you make a defect, like in this video, you can see there's a serosal defect. It's very important that you suture it immediately, because after 2 hours, you won't find it, you forget it. And this is just basic skills. If you want to do colorectal surgery laparoscopically, you have to be able to do a just intracorporal or extracorporal single stitch knot like this. This is intracorporal knot tying. Just you have to do this, and this is also possible to train and train and train day by day outside. There are that you can do just a knot tying. And as I said, be gentle. If you remove the small bowel, be gentle. Don't use the arresting function. And if you have a lesion, just do the lesion immediately. In one of the later modules, I will show you what will happen if you don't do this and the small bowel or the large bowel have a perforation. Try to get familiar with blood control. You have to be aware of using the right instrument for the right plane, for the right region. You have to be aware of lots of hemostatic agents, like on the right video. There are several products on the market which might help you in case of troubles. There will be a lecture only on how to get out of troubles. But the thing is, which you can just look yourself, Get familiar with all these products, go to the companies, they all offer PIC courses how to use the powder or the foam, the antithrombotic foam or whatever, lots of products available. And on the left picture, you have seen, I start the left video again, you have seen that I was just using the wrong instrument for the wrong region, losing the electric hook beside a major vessel. The inferior mesenteric vessel might lead to collateral damage, but also in that case, you have to be able to manage your complication, which can be trained outside the OR. Where can you train this? I don't want to talk too much, just one slide, because it's weakness optic. Use a pelvic trainer, pop trainer, box trainer, however, use it, install it in your clinic outside the OR, put in something, whatever you want to do, and do the suturing, do the blood stopping, and all these training modules, which you can do yourself on meat just from the refrigerator. So this was just in very brief 20 minutes my part for the very basic skills. In summary, take care of your patient, just study the patient's history, introduce yourself, talk to the patient, do a good documentation of everything you did. Try to write down the most important complications, get familiar with the instruments, get the information how and train how to use the instruments, get some idea of how to deal with complications. All this is just most important to start with safe surgery. Thank you very much for your attention.
Thank you very much, Andreas. We're going to continue now with our next speaker.
And welcome everybody also from my side. My name is, as we said, Walter Brunner. Originally, I'm from Austria and I'm working in Switzerland, which is the largest colorectal unit in Switzerland in St. Gallen. And we do a lot of minimal invasive surgery, and it's a pleasure to have now over 350 people in this webinar on the basis of laparoscopic colorectal surgery. And I will tell you a little bit of anatomy and approach, and I will show you the first part is colorectal anatomy and approach thing. The second is a little bit of patient special anatomy, and third, a little bit about anatomy and laparoscopy. So of course, this will be from the surgeon's perspective. I'm not an anatomist, I'm a surgeon, but it's all about layers and planes. And there were some very experienced in the group, and there were some residents, but everybody will know about the layers and planes. And the best thing is, you know them, you find them, you stay with them, and you try to love them the whole life you do colorectal surgery. The first thing is the colorectal anatomy, of course, is derived from embryology. So you remember that this was just a straight one, and then it made some rotations. And this ends up in a special way. We are used to see that. So mainly the colorectal part is derived from the mid and the hindgut structure. And they have midline vascular supply and also lymphatic system. And also the nerves are running around this system. And you see, for example, here is the cecum, and this is one part of the midgut, and everything which is below them is the hindgut. And there is only a few vessels which are coming along with them. The anal canal, and I won't go too close to that because this will be in the last webinars on rectal cancer and rectal surgery. So this will be covered then. And the anal canal, this is a cloacogenic origin. During the elongation and of the colon and the rotation in utero, an additional connective tissue layer is formed and provides fixation to the retroperitoneum. And probably you all know that the colon, of course, it makes the rotations with the whole vessel coming along, but there are some layers in between. And mainly there were two people who told us which layers these are. And the most important thing is that you are able to come into these planes and separate the planes either with the fascia or without the fascia, depending if it's oncological necessary or not. But mainly you can stay and leave those fascias behind. and take the whole intact embryological package with intact lymphatic structures. That makes it bloodless mainly, that makes it also oncological perfect. So I say to my residents, the specimen should look in the end like in the beginning of the operation. So if you put it out in the same way, that could be an operative perfect way. So there are those two guys. It was Karl Told. He was an anatomist, mainly in Vienna. So you can say he's an Austrian. He died in 1920. And Dimitri Gerota, he was born in what now is Romania, also very linked to the Austrian universities. And they both described similar things. Of course, you can say there are more layers than those two, and this is a parietal and a visceral one. But mainly they described what connects the colon to the kidney. And you see in this part, you can just leave it behind with the fascia, or if, for example, the tumor is attached to the fascia, you better take the fascia with you. And it's mainly a similar thing from the surgeon's perspective. So the blood supply of the colorectal side, as I told you before, it's just two main vessels. That's the superior artery and vein, and that's the inferior artery and vein. So you end up with those two in the mid and the hindgut, which is of course not true for the rectum. There are other vessels coming from below, which will be covered in the end. But mainly now we are talking about those two big branches we have, but they divide. And if you consider your approach in a laparoscopic also in an open way, it's the same surgery, just your incisions in the abdominal wall are different, but inside the same thing should happen. So if you imagine you could draw a line which is going from around Treitz flexure to the ileocecal region, and everything on the patient's right side is midgut, and it's supplied by the superior mesenteric artery. And on the other side, everything left side of it is covered by the inferior mesenteric artery and gives you the whole side. So if you consider for example, for the left side, if you want to find the plane, there are three perfect options. The one is at the promontory. You can find very nice the plane you go in. The second, also possible, or the first if you want, is at the inferior mesenteric vein. Also here you will find the plane perfect. Except in the midline, where the artery is originating from the aorta, of course, there are nerves, there are lymphatic vessels. There maybe is more density, so it's more difficult to find exact at the origin of the vessel, but it's better to come from here or at the promontory to find this line. And another one, and this was what we used in open surgery mainly, was coming from lateral. And here you very nice find those Told's white line or Gerota's fascia. If you make your preparation and you cut the vessels, be aware that maybe if you make a left colic resection, you want to have a blood supplied up to here. So don't do a preparation into the arcade, because maybe then you have no blood supply if you cut it. And that happens if you go for the flexure. This will also be a separate module which is dealing with difficult things and the flexure, best flexure mobilization. If you are aware to mobilize the flexure, if you cut in here and you cut the vessel, maybe your blood supply will not be good enough for a stoma, or even worse, for an anastomosis. And if you have a look at this region, so this is the pelvic floor here, you see that this is the promontory, and on this side you see the ureter. And I would recommend that you learn to look on the right ureter every time. And the more you do it, the more you learn it. You see here behind is the ureter. And you can imagine that our line coming from below is coming from here, and everything on this side is going to the left side, and this is the hindgut, and everything on this side of the ureter will be for the right side. So this is an easy case. You see again, here's the ureter. If they are thin, you see that perfect. This is the aorta. You see everything very nice. There is the inferior mesenteric vein. So if you would do a left-sided resection, that would be quite easy. But imagine the smaller, the thinner the patients are, the more difficult it could be to just rupture the layers and go too deep. This is another case, and I ask you who, maybe you use that name, that white line of told. And if you look at this picture, everybody should see the white line. This is just going up. We cut already, for example, the mesenteric artery, the inferior one. And as you see here, this is the white line, and it's very, very small. We go up. This is Treitz flexure. We go to the vein. This is inferior mesenteric vein. And also what you can see is, and this is what you will learn time after time, and the more procedures you do and the experience, they know it already. You see already the border of the pancreatic tail, which is going like this. And of course, we want to cut the vein very close, but not too close to the border, because we don't want to harm the pancreas, which is here. And you see a little bit difference in the yellow from the fatty tissue and to the pancreatic border. So don't rupture here. And be aware that Told's fascia is going behind your pancreas. So if you just follow it up, you will end up behind the pancreas. You see, you can free it, you just touch it gently. You don't want to harm Treitz flexure. So as Andreas said already, touch very gentle, try to secure all the vessels perfect. And you see, it can be easily done with different types, also with the sealing devices. And then you just, if you once have your Told's fascia, your Ureter, you just follow it, the whole plane, and you can just stay in the same line. Even you have to, maybe you need 50 to 100 procedures until you see it as easy as it's here seen. Here it's very nice. This is the white line of Told, which always belongs posterior. So behind that, we have all the nerves, we have the ureter, we have the kidney, we have everything we want to keep in, and we just stay in the same line and the same plane. We don't want to rupture. There are very rare vessels going up, but it's never vessels which are important. It's only very small wedges of the embryological plane. So you see, this is the aorta. We cut here the artery. We see the ureter coming down. We see the testicular vessels if it's a male, and the ovarian if it's a woman. And everything is behind our plane, also the nerves, which went down to the pelvic floor, and we want to preserve them. So if you go in for your approach, and you just think about the peritoneal landmarks of the mesenteric root, and this is the line I drawed you before. So this is Treitz flexure, and this is going for the right side, the vessels, everything from the high jejunum down to the ileum, and then the cecal, the ascending colon. And you can draw this line again from Treitz flexure down to the right ureter. And this is why I recommend to learn to have a look for the right ureter. You don't want to harm it. If you want to make a resection on the left side, you start a little bit left of the ureter and go up to Treitz flexure. And if you want to do the right side, you start a little bit right of the ureter, but you make the same line going up to Treitz flexure. And you learn that the vein is coming here. You want to avoid it. It's the same. If you go up on this side, you will have all the vessels covering the right side. If you go to this side, be aware also the vessels for the jejunum are there. So don't cut it. You only want to have those for the right colon probably. So again, if we go for the right side, where's your best approach to find the plane? It's just at the ileocecal region. You can also go direct to the superior mesenteric vein, but imagine there is the duodenum, because you just start at Treitz flexure. There's the duodenum, there's the pancreatic head. So if you go immediate here and it's not clear for you, maybe you run into problems. So maybe it's easier to come from below, draw your line and lift it up a little bit to have a perfect plane. And of course, from the lateral side, it's also easy. We show you maybe also some video. You see here's the right ureter. It's going down like this. This is ileocecal region. So if we start the video, you see for the right side, we just pick it up and we make those adhesions. We open them, and then the line is just also going to Treitz flexure. We just open up, we lift up everything. This is the last part of the ileum. You see here the ascending colon already, and we just open the peritoneum. And we stay just in the same line, following the line towards Treitz flexure. But we don't want to go too deep, because you see here are some nerves already, and this is the nerves we want to preserve, and we also want to preserve the plane. But if you just open the peritoneum, there below we will have the vena cava. We also don't want to open it. It's of course clear. So if you're not sure, have a better overview, have a look, where's my trades flexure? Because I want to see it, and it's just opening of the peritoneum. We don't harm anything, but we can lift it up and find our way and find towards fascia. This is what we are looking for next. You see here vena cava. Soon you will see that there's trades flexure. We don't want to cut in. And then we're going to look very smooth and very gently. Of course, and this is what you will learn later on. Where are you allowed to grab it? Which instruments you should use? You see, we just opened the peritoneum and we are looking immediate for our nerves and also for the white line. And you see here, very, very gently, you can see the white line also on this side. Should come the next. So, and then there is, of course, a patient's special anatomy, and this is influenced by his disease and the indication you're operating on him. There maybe were previous operations, and never forget there is a kind of variability. So, for example, if we talk about the vascular management and you saw some nice vessels we cut, you can do that, and you should always do that controlled. You don't fear the vessels, you should love them, you should know how to manage them. And whatever you take, that's very nice. There are several options you can do. It should always be controlled. But be aware, for example, this is the disease itself. And when you have a look that this is trades flexure, and you see there are some big lymph nodes. So we don't see the aorta at all. And we are not sure where is the artery. So we can run in a big problem if we just think it's the same. And you really could go, you see that we proceed here. This is the same patient. He had a lot of lymph nodes, and Andreas was pointing out that you should have a look on your CT scan. And this is very difficult. And with these large packages, and maybe this is not for laparoscopy and it's not the beginner's case, but you see there are a lot of lymph nodes around. If you are able to cut this, you should find it before you run in a problem with the aorta. So have a look on the CT, what you will expect in this case. Okay, and let's proceed. Maybe always have a swatting. And then there are a lot of anomalies of the vessels. The mid-colic artery, for example, it gives to both sides, like the Drummond, which is always or very often here, but the real line, the true artery, only in 10%. You should have a look at that. Or the right colic artery, sometimes it's not there. It's absent in 8%. The iliacolic artery goes anterior or behind. If you approach your vein here and you're not sure if the artery is in front or is going below, you should look that on the CT scan. You can make a 3D if you want, but often it's during the operation, it's moving around. There's a mobile organ. So if you lift it up, you just have to very closely look what you do your preparation. And that's also for the left side. Mainly we have one mesenteric inferior artery, but have a look on your CT scan, for example. If your internal arteries on both sides in an old patient are complete stenotic or they're even complete gone, but maybe then you have considered from what is your rectum living. If you just cut here, maybe you will have a big necrosis if all the vessels are gone here. And there's also a variability where the left colic is going, the sigmoid, if they are connected to the other side. So there are some types. You can have a look. Also the veins, especially on the right side at the pancreatic head, there are a lot of types, and you will not always be able to figure that out in the CT before. But if you do your preparation, be aware that the veins in laparoscopy are sometimes much more dangerous than the arteries, because the blood is just coming and you don't have to grab something very perfect, as you saw in the video from Andreas, where he could clip it then. But in the veins, maybe they rupture if you want to grab them, so you run in a much bigger problem. For example, this is at the pancreatic head, you see a lot of vessels, and if you do an oncological resection, you should be able to, in the end, have all the vessels and all the lymphatic part that you want with you, and the other, they should stay inside. Of course, the laparoscopy in colorectal is always an advanced laparoscopy. It's not an easy one. So have a look on your CD, and especially you also look on the difficulties maybe you could face. So you can, for example, have a look, how close will my colon be to the spleen? Not only look on the tumor you are going to resect wherever it is, but also have a look on this. This could be easy, but this could be very difficult also. You can also have a look on the fatty tissue here, which trocar you need, or if you're on the height, for example, of the kidney, the more black is inside, the more fatty tissue you will face. So here is not much fat. You see the fat is here, but not here. It could be a very good manageable case. But on the other hand, if it's a very slim fatty tissue in the subcutaneous and very much fat inside, this will influence your strategy and also your options. So be prepared on that. For example, here you see the spleen is very high, and maybe we see that it's very attached and the colon is extreme close. So maybe you need another trocar, you need somebody to help, and this will be not a simple case if you need the whole flexure to be done. But we will come to that in one of our models. Also, if a patient was operated before, maybe you look in and you want to look on the left side, but you see there is a lot of adhesion. So if you see that there were operations before, be aware that this could maybe just be a laparoscopy and you're not able to do all the adhesiolysis. If you can manage it, that's possible, but I always recommend you have a 30 minutes rule. Tell your anesthesiologist, if nothing is due in 30 minutes, please tell me, because I'm complete in my video and I do my adhesiolysis and I forget the time. And if you make an operation more than 6 hours, maybe it does not make sense anymore and you should go for open, then it's much better. At least there are some nerves, and the nerves are very important for the function. You see here, this is the cadaver model where we see the pelvic plexus. And of course, you should have these nerves preserved after the resection. And this is only possible if you have a look at them, and mainly you see the nerves going accompanied by some very small vessels like this. And also it's often not only one nerve, but there are a lot of nerves going up, and we all want to preserve them. This is an example for the inferior hypogastric plexus, and we will come to that during our models really related to the procedures we will show you. So our main goals, we want to have the intact embryological package with intact lymphatic structures, but also the preservation of the orgone function, which means we should have some nerves left, and only those of the specimen that should be removed, but not the others. At last, the anatomy and laparoscopy. Be sure the anatomy is not on the screen, it's in the patient. And if we do laparoscopy, we think we are only looking on the screen, and it's not a video game. It's also, anatomy is there even if you don't see it. It's out of the field of your vision. The camera gives you magnified options, and maybe some points of view will never have in open. You cannot go with your hand in a very narrow pelvis with your head to have a look at it, but you can do it with the camera. On the other hand, mainly it's 2D, but anatomy is 3D. And you have limited positions with your camera as well as with your hands. The organs, you just can place them with gravity, but not with a hand going in. And at least, and maybe most important, the tactile sense, even if we have some forced feedback, if we have feedback about our instruments, it's nothing against our fingertips. My fingertips will always be better than the instruments. And sometimes that's the only reason you have to convert, to take it in your hand and be sure what is the light. So for the summary, colorectal anatomy, don't forget, this is the most important line you will be able to find. There are always, every patient is special, so he has his own anatomy with variability, and maybe you have some nice fancy tools to figure out what is special at this patient. And don't forget that there is anatomy and laparoscopy, which is different to open surgery, and this will come on, of course, in the next modules you will learn about that. Our main goals, I told them already, the specimen should look the same at the end of the operation, preservation of organ function and nerve sparing surgery. This is what we want to have. And I think, like training, for example, this is one of the largest colorectal, one of the largest laparoscopic and open training courses, and everybody is invited to go there. Andreas is there with me and Colin too. We have the colorectal, hernia, bariatric, and next year also HPV module. And everybody is welcome to join us there. Thanks.
So Victor Tomulescu is going to talk to you, and he's going to continue now. He's going to talk to you about the training in laparoscopic colorectal surgery.
Good evening. My name is Victor Tomulescu. I'm working as coordinator of the colorectal department in Podaras Academic Hospital in Bucharest, Romania. This is my disclosure as teaching and training and proctoring. As you all know, the dissemination of laparoscopic colorectal surgery has been slowed because it's related with a very prolonged learning curve. And there's a good paper published by David Miskovic in 2012 showing us that you need from 100 to 150 cases in order to achieve a good results in laparoscopic colorectal surgery. In Romania, at this moment, we have a 6-year general surgery residency and the basic laparoscopic surgery accreditation when you finish the residency. And it's also a program of complementary studies for advanced laparoscopic surgery certification that it lasts 8 weeks, and you learn adrenal surgery, spleen surgery, upper GI, colorectal, HBV, everything. And that's clear, it's not a very good idea. And we try to accreditate a 2-year fellowship for coloproctology but will be a long drive for this. We have started from 2000 to do training workshops in laparoscopic colorectal surgery. And we do in my hospital 2 to 4 training workshops per year using an animal model. And this have been EAS endorsed. And there are also 2 per year master classes in the national societies congresses like General Surgery or Romania Associations of Endoscopic Surgery. But the results were very poor. So when we have done the first audit in 2008 as secretary of the Romanian Association of Endoscopic Surgery, there have been 2.5 cases by colorectal laparoscopic surgery done in Romania. In 10 years, we have reached 7.45. So that's a problem. And we have looked what the problem is. It's clear that laparoscopic colorectal surgery is a very challenging procedure and frequently is self-taught by senior surgeons. So when they come to our courses, they come back and they do not know what to do in a very challenging case. So maybe we have to look for a different approach. And looking how we can improve, we have seen that there was a tremendous rise in the laparoscopic colorectal surgery in the United Kingdom from 5% in 2005 to almost 40% in 2012. And what have been happened? There was definitely an involvement of the government, an involvement of the National Institute for Health and Care Excellence, NICE, United Kingdom, that have considered that all suitable patients should be offered the laparoscopic resection for colorectal cancer. So they have considered to train the surgeons. But first of that, they have considered that maybe it's good to train them for laparoscopic colectomy and then for rectal cancer surgery. And so have started the Lapco training program in United Kingdom, and we have looked very careful at that program. There have been a fully preceptorship program with a structured program with national trainers. The trainers have been the key of this program, and also the selection of the surgeons. So there was a 2 to 3 years program of training, and 150 consultants, colorectal surgeons have been involved, and using at the beginning both model training, fresh frozen and anesthesia pigs, showing that the fresh frozen cadaver are better than anesthesian pig. Unfortunately, in Romania at this moment, we cannot do training on the cadavers. And also, what's important is that it's a program with proctoring, with individual number of operations supervised by an expert laparoscopic surgeon, first in an in-training center and then in an outreach hospital. And all the time, there have been an evaluation of the moment of the candidate selection, of evaluation of the training progress, and then the monitoring, and then the assessment of the audit and the audit of the outcomes, and another assessment after the signing of the candidates. So looking very careful of the results. And each training case was monitored using a validated global assessment score. That's very important. And every procedure has been structured in 12 to 15 parts, and every trainee, every trained separately for every part of it. And the results was astonishing, I've considered. So the adoption of laparoscopic colon surgery have risen from 5% to 60% in 2016, as the National Bowel Cancer Audit have shown. And the learning curve have been shortened from 100 to 150 cases to 20 to 40 cases, as the results that have been published in Annals of Surgery have been shown. That's very good results. But the problem is that they have trained very well the trainer, and the trainer have been also very evaluated by himself and by the trainees. And there is a structured trainer assessment report that have been very well evaluated at the end of the program. Because we have to realize that not all surgeons are good trainees. You need to have enthusiasm, confidence, but also to have an empathic orientation for training when you try to do the training in laparoscopic colorectal surgery. And the trainer have to be aware with the trainer needs and to make the trainee to continue to progress, but always keep in mind that the patient have not to be affected at the moment at the training. And the improvement of the training was reached by using a model that have come from endoscopic, from the program for training in colonoscopy in England. And it was the Lapco Train the Trainer program that have reached this goal. And this program is a learner-focused framework, and always keep in mind that you need to deconstruct the skills and to promote to the trainee how you intervene and how to make them understand and how to make the work go around. And always at the end, there have to be feedback and to show to the trainee what is good, what is wrong, what should be improved. And this is the Lapco Train the Trainer, who make trainer from unconscious competent to consciously competent educator. So it's only in England. So we have looked if it's only that that program that works, or if it's something that goes also abroad. And we have found that that move out the ocean, going up like Lindenberg to the Atlantic. And in Houston have been the first Lapco Train the Trainer in colorectal surgery. And the surgeons from there have added to the program of England something very interesting, the telementoring. And this is because they cannot go and operate in the hospitals where they do not have accreditation to operate. So at the moment of the training, they train the trainees also for the telementoring. And this is a thing that the Laparoscopic Society in America, in the United States, have moved. Also considering that the telemedicine will be a very good opportunity for training in laparoscopic colorectal surgery. and the new pandemic, the COVID-19 pandemic, have shown us that we have to consider also the telemedicine for training. I have been part of the Medtronic pathway for colonic training, laparoscopic colectomy training, and this was a very good idea for them to go to Eastern Europe, Middle East, Africa, and do for the beginning the trainer course, and then the clinical immersion, the master classes and involvement. And I will show you what I have done as a pilot project in Romania. This was the first trainer course, and then there was a selection for the trainees and the master class, and the program was with mentorship and clinic case review, and then a video review, and 1 year follow-up after graduation, the program. So that's a very structured program. And very important was the trainee selection, because you have to select trainees that know how to do and have some experience with colorectal operation, and also have some experience with laparoscopic general surgery in order to go to laparoscopic colonic surgery. And then have to be clinical immersion in which you can train 2 trainees, and you have to schedule at least 3 operations to show them the step-by-step procedure. And then the most important is the one-to-one mentorship, in which you have to go and help the trainee in order to achieve good results and the safe laparoscopic colonic resection for the patient. And at the end will be a video coaching and the video evaluation, and you can discuss with the attendee all the good things and the bad things of the video. And at the end, you have to follow the trainee 1 year after and follow the results. And this is the first master class. What we have done in Romania, we have been 2 trainers in that masterclass, one from Bucharest and one from Cluj-Napoca, and 4 trainees. And we have learned for the beginning that we have to tell very clear to the trainees how we have to step in, because sometimes the trainees are older than us, and sometimes it's very difficult to stop them. So they have to be a structural process for stepping in, and you have to leave them do the things, but always keep in mind the safety of the patients. Clear, the main challenges have been with the case schedules, but we have surmounted this, and also the long distances that are between the towns have been surmounted by the telementorship, and we managed to use the telementorship in order to do the proctoring. And there have been good results. We consider 3 of them have completed the pathway. The 4th one have ended the pathway because the technology issues. And you have to consider this in our country, because if there is the technology issues, you cannot, okay, you have to buy another trolley to operate. And there have been a raise in laparoscopic approach in colonic surgery for 2 to 40% in emergency cases, and 30 to 90% in scheduled chronic cases. And this is very good results for us. But have been good results for trainees also, because we use this model also for other trainees, like for thymectomy, pelvic lymphadenectomy, or robotic rectal surgery. I'm doing a lot of robotics, and I'm doing also teaching in robotics. And the young surgeons participating in teaching, because you have to ask to come with the team, and there are also young surgeons looking how you teach them the laparoscopic colonic surgery. They want to, and they are eager to be involved in this pathway. And in this moment, there are 2 young other surgeon in the pathway with myself and another one in Craiova. And my trainee from the other hospital have started also to train young surgeons in the same pathway. So it's very important for the trainers also. And we have considered that the next step will be the involvement for the whole country. And I, as General Secretary of the two society of colorectal surgery and laparoscopic surgery in Romania, if we bring together the societies and the Medtronic in order to go for the pathway, going for the Lapco, train-the-trainer model, and then the clinical immersion, the video coaching. Unfortunately, the pandemic have come, the COVID have come, and everything have stopped. And the master classes cannot be done. The train-the-trainer should be done also by as a webinar. And maybe this colorectal webinar series will bring the knowledge for them. And then definitely my opinion is that we should go for one-to-one proctorship in order to achieve proficiency at competence. Thank you all for the listening to me.
We now go to the next section, and that's where all the questions you have asked in the last couple of 1.5 hours will be answered. And I'm gonna just ask them to the individual panelists, and I'm gonna start off with Andreas, because he had a lot of questions on basic laparoscopic skills, but if the others want to intervene and have questions as well or answer the question, please feel free to answer them. Andreas, one of the first things where a lot of questions were about the tattooing of the tumor, and one of the questions was, how long do you need to wait after tattooing, and can you operate the same day? And one question I added is, how long will the tattoo be visible?
So the first, you can do it on the same day, but you should use CO2 gas for the endoscopy. Otherwise, it will be difficult to do a laparoscopy because there's lots of air in the large and small bowel. So better to do it in advance, and you can do it either the day before. Our experience with spot or ink is that you will see it up to 4 weeks. So you can do it a few days anytime, 1-2 weeks, except up to 4 weeks prior to operation. In our clinic, we usually do it the day before the operation.
Why not have the deal with the gastroenterologist that they tattoo any tumor they see? So they tattoo with us, our clinic, they tattoo the tumor when they find the tumor.
Very good question. So the outside gastroenterologists do not get it paid. So unfortunately, we have to do the second endoscopy for the patient if they find the carcinoma on the right flexure, and they won't pay it for themselves. And in our clinic, we have an interdisciplinary endoscopy center. So surgeons do endoscopy, gastroenterologists do endoscopy, and we share each other. And if someone finds a carcinoma, the gastroenterologist calls the surgeons to show him immediately, and either himself or the surgeon does the tattooing. It's just a really good functioning interdisciplinary group.
That's the same with us at our clinic. All the tumors are tattooed immediately, so there's never a discussion. Another question about tattooing is, do you also tattoo the rectal cancers?
Yes, there's just one exception. If you have it really at the sphincter and you have to do an amputation, then we do not do it. But usually we do up 2 centimeters and higher. We do always a tattooing below the tumor.
Okay. Do other panelists want to add something? No. Another question is, how do you know the size of the staplers you use? And that's question was one for the circular stapler and one for the straight stapler. How do you know it, and can you read about it anywhere?
There's some papers showing that the stenosis rate of circular stapler anastomosis is indirect proportional to the size of the stapler. So the larger the stapler is, the lower stenosis you have. My personal experience is if you have a good blood supply, no ischemia, no tension anastomosis, no mini leakage, stenosis is really, really seldom. We usually use a standard, a 28 or 29 millimeter circular stapler, and almost a rigid sphincter might be the biggest problem in elderly patient to use a bigger stapler. In very low rectal cancer, we also try to use the 33 centimeter stapler if we get it in.
Yeah. Other question, and that's a more general question, is do you have standard trocar placements for different procedures?
Yes, we completely standardized for right colon and for left colon and rectal cancer. I showed it for the left colon. We have 4 ports, and the optical port in the right upper quadrant, not in the midline, not at the area of the umbilicus. We always try to put the optic port outside, opposite to the region of interest, so we have a better view. And I think to the next modules, we will see lots of videos, more videos than today, to show how we put the ports in the right position. But it's completely standardized for left, right, and rectal cancer.
Okay. Do you have a preferred method for the first trocar? Do you do it open, or do you use the Verus needle?
So we standard use the Verus needle, except there is a multiple previously operated patient, then we almost do an open approach with a balloon trocar. We never use optical ports because, to my personal experience, they're very dangerous. And I will show this in the module for how to get out of troubles. Okay. Just from previous operations, if there have been just cesarean section or hysterectomy through a median lower laparotomy, usually there are no adhesions, so we also use the Verus needle.
Okay, how is this for the other faculty members? Because in the Netherlands, the Verus needle is kind of condemned, and it's hardly any used by general surgeons anymore. So everybody is doing open introduction of the first trocar, and it's almost considered a mistake. It's completely relative, or it differs between countries. But how is it in Walter's or in Victor's country?
So actually, we mainly do open approach for the first port, but there are some who doing Verus needles. So that really depends. It's open in the country, but there are several reasons why you should not use the Verus needle if it's not an elective primary case. In all the other cases, you should use the open approach for sure.
Okay.
Just one comment, Colin.
Yeah, sure.
I can say for Austria and Germany, there are decisions from the highest court that it's no medico-legal failure if you use it. There's stated no difference in the risk if you do it open or do it by Verus needle.
No, I understand that, but it's always.
You can't be sued. You can't be sued if you use the Verus needle.
Also an interesting question is, how can you what is the safest part to handle the small bowel and the large bowel? So how do you handle when you position it at the place where you want to position it? How do you handle it?
First, it's important to do the right placement of the table, to put the patient in a steep anterotendental position and turn it, if you do the left colon, on the right side. Therefore, I said you need a good anesthesiologist, and all the forceps have just on the handle. They have usually an arresting mechanism. I think you have to open this so that you have it in your hand, how many force, how many power you put on the small bowel. And it's usually better to grab it on the meso and not on the small bowel itself for general. Even if you have some ileus or some inflammation there, it's very rigid. The small bowel might open very easily. But sometimes in very fatty patients, you get very easily bleeding if you grab the meso. But usually we recommend for beginning using the meso, grabbing the meso, but never close the rigid of your handle grip.
Okay. Other members who have comments on this? I think it's a very good advice that you don't close the forceps with the locking device, because when you forget, you tear the mesentery of the small bowel. And I always prefer not to touch the bowel, but just the appendix aploica or the mesentery. And really important is the positioning of the operating table. So you need a good fixate. The patient should be fixated really properly, so you can do extreme positioning, and the bowel will fall out of the way easily. There are a lot of questions which will be answered in the following modules. Questions like, do you prefer medial to lateral approach? What was one question to Walter? And also some other questions. But one interesting question to Walter is do you always need to dissect the ureter if you do you want to see it, or is it enough if you know that you're in the correct plane and the ureter is behind that plane?
So you should never dissect anything which is not necessary to need. But nevertheless, if you try to figure out where the ureter is and you learn how you see it, the easier it gets for you. I just don't want to harm the ureter. So if you completely dissect it, probably you have a denudation and then you have a problem with the ureter. That's not the idea. If you can keep the complete Toll's fascia closed, that's perfect. But normally in most patients, you are able to see the ureter if you're focused on that. And you just, it always is crossing the artery. You just have to see it. You don't have to dissect it. Before you cut the artery, you have to be sure it's coming out of the aorta and it's not the ureter. That's also clear. And be aware, some have a ureter duplex. So you can also, even if you found one, there could be a second one.
Yeah, not often, but it's possible. Yeah, I agree with you. Personally, I prefer to see the ureter before I cut the artery. So it's you don't have to dissect it, but at least see it. So it must be it's always visible if you look for it. Yeah.
Actually, I would recommend, and you will see that in the videos later on, probably when we run through the models. If you do not find the ureter, but you see that the plane is completely closed, so you don't have to open it to find the ureter. This does not make sense. If your situation is unclear, then don't proceed on this position, but use one of those three best approaches I showed you. Maybe come from the lateral side, come from above, find the plane and stay in the plane. This is difficult if there is a lot of inflammation and there is tumor, but then try to approach around it and not go direct there where you have the problem.
In my personal opinion, I'm sorry.
Can I comment something?
Yeah. Yeah.
I think that will be more difficult for diverticulitis not to see the ureter. My recommendation is to look for ureter if you go for a benign disease more often than when you go for cancer. Walter, what is your opinion?
I think I know what you mean, but I think it's always the same. You should be clear that you are away from the ureter. And if you are able, for example, in the sigmoid diverticulitis, most inflammation is in one part. Mainly it's anterior, but some are going to the mesentery. So better you start a little bit higher to find the ureter where there is no inflammation. then I totally agree. You can follow the plane. And if it's from the beginning on the CT, you see that there is also stenosis of the ureter, you have to put in a double J catheter before you go for the operation. That's much better to clarify it and not run into a problem. And that's true for tumor and for inflammation.
That's my opinion too. Thank you.
Yeah. And Walter? And I think we agree that if you start with the surgery, you have to look, not to prepare, you have to look for the ureter in all the cases at the beginning, because if you don't get your eyes trained on where it usually regular is, you won't find it in the difficult cases. So even if it's not necessary, you have, to my opinion, for the first 100 cases, try to find it, not to bring it out of the vertebral fascia, to find it, to locate it. That's enough, but do it. And then it will be also possible in the difficult cases.
If you saw my video for the right side, I did not cover it at all, but I train my youngers. It's always the same procedure steps. And step number 3 is have a look on the right ureter every time. Yes. Because then you learn, as you say, then you learn how to find it.
Yep.
Thank you. So we're going to progress to the training questions. And there were a lot of questions if they could apply for fellowships in your hospitals. So I'm not sure if this is the correct venue for this, but how is the training in your countries organized, Walter? Are there fellowships in Switzerland, and what's your idea that how should a colorectal surgeon be trained and how much should he do?
So first, if you go in the literature, all those more simple procedures like a cholecystectomy, hernia surgery, appendicectomy, they have learning curves around 30 to 40 cases. If you have a good trainer and the caseload that you can do it in between 1 or 2 years. If you have a look on the more complex procedures, and this is also colorectal surgery, it's all going up a little bit to 45 to 50 cases you have to run through until you figure out how the steps are. Then you are not a super experienced, but that is what you have to expect as a learning curve to run through the major steps. That's the first thing. The second thing, in Switzerland, of course, there are training programs. During your education, you have to do colorectal surgery, you have to do laparoscopy. But we recommend, nevertheless, that you go for master classes, that you have a training program you are running through. And there is some master class in Switzerland. We have those Davos course where they are forced to go. That's open for every country. And of course, they can go in another country for like a master class.
Victor, do you have something to add?
So in Romania, there are no fellowships at this moment for foreigners. So, but there are programs in development, but we will see what will be after the COVID, because at this moment, I don't know if they can come in from abroad in our country to be in our hospitals. What is in Holland or in Austria is the same?
So in Austria at the moment, no foreign surgeons are allowed to come in our clinic. Usually outside of COVID, it's always possible to come and be part of the team as a visitor. You are in the OR, you can assist, but if you want to do just operating, you have to do some examinations. The most difficult one is the German language examination. You have to be registered in the Austrian Chamber of Doctors. So to perform operations in the OR is difficult. To be for 2 to 3, for 6 months in the OR, assist my team, assist me during colorectal or other laparoscopic procedure is easy.
Yeah, for the Netherlands, it's for foreign residents to be part of the training program. It's quite complex because we have a lot of residents we have to train ourselves. So it's always possible to visit, but to actually participate, that's also a financial thing. There's no funding, so residents should arrange from abroad should arrange their own funding. So often that's not possible, and most of the times academic hospitals have options for that. But for more private hospitals, that's much more difficult. So continue with the training. There were some questions about how you could train in a box, and correctly they state from if you train on meat, you can train some not so complex training skills, but how do you train more complex training skills like dissection and those things? And I think this is a nice question for Walter. So Walter, how do you train that? And keeping Davos in the back of your mind.
How do you train?
More complex things in a box, in a training box.
So I saw that there were some questions if there is a place for that, and of course we have procedures which have the dissection technique. So if you do colorectal procedures, you have to be able to manage the vessels. You have to be able to suture. You have to be able to make a proper dissection in easy, but also in difficult situations. And of course, you have the old stapling thing to get familiar with all those techniques, because there is mainly is stapled anastomosis in the colorectal setting, but you should also learn to have that intra and extracorporeal, but not only extracorporeal. So for example, we have modules which cover the vessel and the bleeding management, how to proper dissect, as you saw in the video, the vessels that you have a nice oncological resection. So then you must be able to dissect and to avoid the bleeding or to handle the bleeding.
I agree. And like you already mentioned, the Davos course has many modules where you can actually train complex procedures when it's bleeding, and the POP trainer is extremely important for that. So I advise all residents to go there and train your skills. It's almost impossible to do that in your hospital yourself, because they're often quite expensive modules and trainer. So that's why it's so important that these courses stay there, and hopefully after COVID has disappeared, we can all come back to Davos and train on those trainers. Yeah, sure.
So for the boxes, I think suturing will be a very good model, because they have to know to master suturing in colorectal surgery in order to make a good anastomosis, for example, for the right colon. This is one thing. And for the dissection, maybe the animal model could be a solution. I use for dissection, for example, the stomach model. And if you go under the serosa for the stomach, it's exactly like you make for the dissection for the colorectal or for the gynecology also. And could be a good model for dissection if you do not have the cadavers for. And also the PIC models will be a very good model for mastering the bowel preparation. So you move all the ileum upwards and downwards, learning how to have a good space for operation. This is something I want to comment.
Okay, thank you very much. So we have some time for a couple of questions. We have a couple of minutes left. I see one question, and I'm going to ask that to Andreas. How much degree of Trendelenburg is safe?
Good question. We never lost a patient on the table, but you can definitely have 30 to 40 degrees without losing the patient. And one of the first failures made there is putting shoulder protection, because some are afraid that the patient goes down. So if you use shoulder protection, this is very dangerous. If you get paresis of the brachial plexus. We always do 30 to 40 degrees and we never lost the patient. But
I might add, you need good fixating material. We use a beanbag, or you need a special material where the patient is lying on so they don't slip, because you need to fix them a little bit, otherwise they will slip.
Yeah.
So the people should realize that if you don't fixate the patient, it is possible that the patient slips.
Of course, you have to fixate. You have to fixate on the arm and the legs, and we have also just something like a rubber where he's down. We don't use a vacuum, the vacuum mattress, because this just makes the place for working a little more narrow.
Personally, I prefer those, but there are all things that we personally like and other people dislike. So that's also what you're used to and what your hospital has and what possible financially is possible. So yeah. I think it will differ from country to country. So I think I'm gonna wrap up the session. It's 6:30. And I'm going to continue to the modules, which I'm going to repeat 11 modules in the coming year. And the first 3 will be for the summer. So the next module is coming Monday. So you can still register for that. And the others, you will find the link in your email and you can register afterwards. Thank you again for the great presentations. Victor, thank you as well as guest faculty, and have a great evening.